Hi guys, and welcome back to another video. In this video I will be talking about vitamin D metabolism and the importance of vitamin D and rickets, the vitamin D deficiency in children and its types. And apart from that, its etiology and the clinical features and the radiological features and the treatment for vitamin D deficiency in children. The vitamin D exists in the form of 7-dehydroxycholesterol in the skin. In the presence of ultraviolet B radiation from the sunlight, it is converted into cholecalciferol, so which is also called the vitamin D3. So this cholecalciferol is converted into 25-hydroxycholecalciferol in the presence of 25-hydroxylase. This enzyme is present in the liver. And 25-hydroxycholecalciferol is converted into 1,25-dihydroxycholecalciferol in the presence of 1-alpha-hydroxylase. So this enzyme is present in the kidney. So some kidney related diseases causes deficiency of the 1-alpha-hydroxylase, which causes reduced production of the 1,25-dihydroxycholecalciferol, which is also considered as a calcitriol. This is the active form of the vitamin D. And the 25-hydroxycholecalciferol is the storage form of the vitamin D. The calciferol is the supplementary form of the vitamin D. The functions of the vitamin D. The vitamin D functions are mainly on the bone. So it regulates the calcium metabolism. So it increases the uptake of calcium by the bones and improves the mineralization of bones. It acts on the gut and increase the absorption of the calcium from the gut and increase the serum calcium levels. It acts on the renal tubules and increases the renal reabsorption of the calcium and increase the serum calcium levels. And it has a negative effect on the parathyroid gland. It reduces the release of the parathyroid hormones from the parathyroid glands. So deficiency of the vitamin D causes increased parathyroid gland activity that leads to the increased production of the parathyroid hormone. It causes demineralization of the bone, and that's how it increases the serum calcium levels. So deficiency of the vitamin D. In case of a deficiency of the vitamin D, there is a high levels of parathyroid hormones are present in the serum. So rickets. Rickets is the disease of growing bones. So growing bone means the growth plates are not fused yet. Not fused due to deficiency of the vitamin D. It can be due to deficiency of the vitamin D or reduced calcium levels and the phosphorus levels. Reduced calcium levels and the phosphorus levels can also cause rickets. There are two types of rickets: the nutritional deficiency rickets and the refractory rickets. The nutritional deficiency rickets is it can be due to vitamin D deficiency or any malabsorption syndrome or reduced exposure to the sunlight and reduced calcium diet. And the refractory rickets is of three types: the VDDR1, which is the vitamin D dependent rickets type 1, and the VDDR2 and the familial hypophosphatemic rickets. So we will talk about this later. And one more thing is the nutritional deficiency rickets will respond to the vitamin D therapy, whereas the refractory rickets do not respond to the vitamin D therapy. So it won't respond to the vitamin D therapy, but the nutritional deficiency rickets is response to the vitamin D therapy, and the nutritional deficiency rickets is the most common type of rickets that we see. The clinical features of the rickets: in general, the child is irritable due to the bone pains, and there is a seizures. So the child will have seizures due to hypocalcemia. And due to hypocalcemia, there is a hypotonia of the muscles and weakness of the muscles, and also the failure to thrive due to the deficiency of calcium in the body. And also, in particular, in head, there is a delayed closure of the anterior fontanelle. Generally, the anterior fontanelle closes at the age of 18 to 24 months. But in case of rickets, the anterior fontanelle won't close even after the 24 months also. So this is one of the clinical feature of in the head. And also the frontal bossing. The frontal bone will protrude out like this. It will come out like this. So I can show one picture here. You can see the clinical picture of the frontal bossing. So the craniotabes. Craniotabes is when you palpate when you press the head of the person with the rickets, you feel like you are pressing a ping pong ball. This is due to the reduced mineralization of the bones of the scalp. And also there is a delayed eruption of the teeth is also observed in a patient with the rickets. The specific features of the rickets include the rachitic rosette and the Harrison's sulcus. In rachitic rosette, the costochondral junction, this is the cartilage, this is the rib, this is the sternum. So this is the costochondral junction. At this junction, due to reduced mineralization of the bones, there is a growth. So it looks like a bead. So the beaded appearance of the costochondral junction is observed in case of rickets. This is the specific feature of the rickets. Generally, the chest wall will be like this, but in case of a patient with the rickets, there is a depression. So depression of the chest wall. You can see the clinical photos here. I will display clinical photos here. There is a depression of the lower chest wall. So generally the tone they have less tone. The patients with the rickets have less tone. So due to pull of the diaphragm towards the center, there is a depression in the lower chest wall. So this is the Harrison's sulcus and this is the rachitic rosette. This is also called as ricketic rosette. So along with these features, the person will also have pelvic abnormalities, which are not problematic in case of males, but in case of females, these pelvic abnormalities can cause obstructed labor during delivery. And apart from these, the person will have increased risk of fractures due to the soft bones. There is no mineralization, the bones are soft, so there is an increased risk of fractures. Generally, what happens in mineralization is, in the presence of vitamin D, the chondrocytes uptake the calcium and they undergo hypertrophy. Then they undergo apoptosis and leave the calcium in the bone. So this is how the process of mineralization happens. So coming to the X-ray findings, generally the X-ray findings are prominent in the X-ray of the wrist and the knee joint. So we need X-ray of the wrist and the knee joint. So see here. Generally, the bone of a normal person will look like this, and this is the diaphysis, metaphysis, and the epiphysis. In between these metaphysis and diaphysis, there is a growth plate, and here the chondrocytes going hypertrophy and releases the calcium here, and causes mineralization of the bone in between the metaphysis and epiphysis. So the zone between the metaphysis and the epiphysis, where the calcification is high, is called the zone of provisional calcification. It appears like a white line on the X-ray, which is very prominent, but in case of rickets, the zone of provisional calcification is absent. This is the first clinical finding. And apart from that, In between the metaphysis, so this is the metaphysis, this is the epiphysis. In between the epiphysis and metaphysis, there is a high cartilaginous growth. So due to the high cartilaginous growth, the metaphysis will be pushed or depressed like this. This is called cupping of metaphysis. This is called cupping of metaphysis. And due to the growth and hypertrophy, due to the growth of cartilaginous tissue, here the bone will expand. So the bone will expand. So with that, the metaphysis as well as the epiphysis will also expand. So we also observe the widening of epiphysis as well as the splaying or the spread of the metaphysis. Splaying of metaphysis is observed. And apart from this, there is a delayed calcification of the bone, which causes delayed appearance of the epiphysis, which is most commonly observed. So the epiphysis is not observed here in the X-ray. So epiphysis is not clearly observed in the epiphysis. These are the clinical features. The main thing is cupping of metaphysis, absence of zone of provisional calcification, and splaying of metaphysis, and also widening of the epiphysis due to the growth of cartilaginous tissue. So these are the radiological features that we observe in case of a person with the rickets. So the therapy for the management of the nutritional deficiency rickets is straws therapy. So which we give oral bolus doses of vitamin D in this therapy. In a person who has an age less than 12 months, we give 2,000 international units of vitamin D per day. In a person who has an age in between 1 to 12 years, so this is 12. So in between 1 to 12 years of age, we give 3,000 to 6,000 international units per day. In a person who has age more than 12 years, we give 6,000 international units of vitamin D supplementation per day. For about 12 weeks, we continue this therapy. After this, we go for a maintenance dose of 400 to 600 international units of vitamin D per day we will give. So this is the maintenance dose. Apart from this, we also provide the calcium supplementation of about 30 to 75 milligrams per kg body weight per day for about 2 months. So after 4 weeks of starting this therapy, we go for an X-ray and we check for the improvement in the X-ray findings. If there is no improvement in the X-ray findings, generally the children will have improvement in the X-ray findings after 4 weeks of starting the straws therapy. But if there is no improvement, radiological improvement is observed, we suspect the refractory rickets. So the refractory rickets which is not responding to the vitamin D therapy after 4 weeks is considered as the refractory rickets. It has 3 types: the VDDR, the vitamin D dependent rickets type 1, and the vitamin D dependent rickets type 2, and the familial hypophosphatic rickets. So in VDDR type 1, there is a deficiency of the 1-alpha hydroxylase enzyme. So 1-alpha hydroxylase enzyme deficiency leads to no conversion of the 25-hydroxycholecalciferol into 1,25 dihydroxycholecalciferol. So there is no the calcitriol formation if there is a deficiency of the 1-alpha hydroxylase. So there is no active vitamin D in the body for mineralization. So in this case, what we do is we give a 0.25 milligrams of calcitriol per day as a treatment. So about after about 6 to 8 weeks, the patient will respond to the therapy and there is a radiological improvement is observed. After 6 to 8 weeks, there is a radiological improvement is observed. And the VDDR type 1 and the VDDR type 2 are autosomal recessive inheritance types of diseases. And in VDDR type 2, the vitamin D dependent rickets type 2, there is an end organ resistance to the calcitriol. So the receptors, even in the presence of adequate amount of calcitriol, the end organ, the bones are not responding to the vitamin active form of the vitamin D. So, and also in this case, there is a high chance of having epidermal cyst, alopecia, which is the hair loss, and also hypotonia of the muscles, which the muscles become very weak, which is observed along with the rickets. So this is about the VDDR type 2 and the familial hypophosphatemic rickets, which is X-linked dominant, and it can be due to X-linked dominant and the autosomal recessive. So we'll talk about this in detail. Treatment for VDDR type 2 is IV calcium in supplementation. IV calcium supplementation. After so long time, there is a improvement in the radiological findings. So, but the treatment is not satisfactory compared to the other types of rickets. So we give IV calcium in case of VDDR type 2, and we give calcitriol of 0.25 milligrams per day for about for a long period. After 6 to 8 weeks of duration, we can see the radiological improvement in case of VDDR type 1. And let's discuss about the familial hypophosphatemic rickets. Generally, in case what happens in case of familial hypophosphatemic rickets is, since it is familial, it can be due to X-linked dominant and autosomal recessive and hypophosphatemic. There is a reduced phosphorus levels in the blood. So what happens in familial hypophosphatemic rickets is, there is a gene called FEX gene which regulates the production of endopeptidase. So this endopeptidase breaks down the factor FGF23. So when there is no breakdown, when there is a defect in the FEX gene, there is a reduced production of the endopeptidase, which causes increased availability of the FGF23 factor. This FGF23 factor, what it causes is, it increases the excretion of the phosphorus from the renal tubules. Excretion of phosphorus from renal tubules. Apart from that, it also causes it also decreases the 1-alpha hydroxylase in the kidney. So this is how it increases the excretion of the phosphorus as well as the decreased production of the active form of the vitamin D. So how we will evaluate this case? So in on investigations, there is a decreased levels of the phosphorus in the blood, as well as there is an increased serum alkaline levels are observed on investigation. So what is the treatment of choice for this familial hypophosphatemic rickets? There is a solution called Jolly's solution we give, which contains about 30.4 milligrams of phosphorus per kg body weight we give. At high doses, it causes diarrhea. So the only side effect with this is with the high doses only. So at high doses, it causes diarrhea. Along with this Jolly's solution, which contains the phosphorus, we also provide vitamin D supplementation. We also give vitamin D supplementation as well as the calcium supplementation. So till the till the radiological improvement is observed. Until that, we should continue the phosphorus as well as the vitamin D and calcium supplementation. So There are, apart from the X-ray, we also have other investigations for detection of the different types of rickets. So let's discuss that. Apart from the X-ray findings, we also have the different levels of blood values of these elements. So in case of nutritional rickets, there is a decreased calcium level is observed, and also in every type of rickets, there is an alkaline phosphate increase in the alkaline phosphate levels, and the phosphorus levels are maybe normal or maybe reduced, and the 25 hydroxy cholecalciferol and also the calcitriol levels are normal in case of nutritional deficiency rickets. And in VDDR type 1, when there is no 1-alpha hydroxylase for the conversion of the 25 hydroxy cholecalciferol into the calcitriol, so there is no or reduced levels decreased levels of calcitriol, and also there is an increased alkaline phosphate levels are observed. So this is about the VDDR type 1 and VDDR type 2. There are normal levels of calcitriol. The calcitriol levels are normal, but the end organ is not responding to the calcitriol. So there is a normal levels of calcitriol, increased alkaline phosphate, and also along with this, there is no the end organ is not responding to the vitamin D. So there is an increased levels of parathormone, and in familial hypophosphatemic rickets, there is as discussed, there is an increased alkaline phosphate levels and decreased phosphorus levels in the blood, and the 25 hydroxy cholecalciferol and 1,25 dihydroxycalciferol are normal. So this is about the investigation findings in different types of rickets, apart from the X-ray of the elbow and X-ray of the wrist and the X-ray of the knee joint. So apart from the various types of rickets that we have discussed just now, there are some other causes of rickets are also present. So first one is the chronic kidney disease. In case of chronic kidney disease, there is a decreased levels of 1-alpha hydroxylase, so which causes decreased levels of calcitriol and decreased mineralization. So apart from that, the renal tubular acidosis. In renal tubular acidosis, there is an increased excretion of the phosphorus from the renal tubules. This causes decreased mineralization. And in case of tumors, there is an increased levels of factor 23, which causes increased excretion of phosphorus. This causes decreased mineralization and rickets. And in fluorosis also, there is a decreased mineralization, increased levels of fluorides, in the community water, and the people will have the bone pains. There is a mottling of teeth, and similar complaints are also observed in the family. This is how we will detect a case of fluorosis. Thanks for watching this video. If you really like the video, give a big thumbs up. The reference for this information is OP Guide, textbook of pediatrics, and Maheshwari, textbook of orthopedics. So please share this video with your friends, and for any suggestions you can put it in the comment section, and subscribe to the channel. Thank you.